بنوجه لهم الشكر مره تانية، وبنتنقل بعد كده بقى للدكتور عفيفي بيه والساده الشير بيرسونز والتكيدا سيمبوزيوم. شكرا.
ألف شكر.
We are welcome the chairpersons of the such sessions, Professor Wahid Dos and Professor Noha Al-Naqib. And I would like to present Professor Afifi from Zagazig University to present his talk, How to Sequence Advances in Therapies in IBD. اتفضل يا دكتور عفيفي.
شكرا دكتورة مها. حضرتك سامعاني؟ دكتورة مها.
سامعينك يا باشا، سامعينك.
تمام. انا بشكر حضرتك جدا على البرزنتيشن، وبشكر اساتذتي في الجمعيه المصريه وكل زملائي الاساتذه الاتندي اللي حاضرين. وطبعا انا مشفق على الجميع، احنا بادئين من الساعه 4 واحنا دلوقتي اولموست عدينا 8، فكان الله في العون. الحقيقه this is a common picture or graph about the progressive nature of bowel damage in Crohn's disease. والحقيقه في واحد زيه برضه للالسرتيف كولايتس. احنا عندنا هنا في here we have two problems, a preclinical stage which said that the patient has a long time before diagnosis, and at the time of the and the clinical manifestations, here there is a structural damage, there may be stricture, fistula, and your patient may need surgery, and as we all know, surgery doesn't end the story of Crohn's, and there is another stricture and a vicious circle occurs. There is an important study by Siegel 2020, and this is an American study which has a very important information about the current state of IBD in the state. It is demonstrated that significantly fewer patients with UC or CD proceeded through treatment pathways that included biologic therapies compared with non-biologic therapy. Here we are talking about the states. In United States, fewer patients. Very few patients also with UC were initiated on biologic therapy, even fewer treatment pathways observed that included biologics as part of combination therapy. And there is a surprise when they make this survey and this study. The most common initial UC treatment was 5-ADA monotherapy followed by corticosteroid therapy, and the most common initial Crohn's disease treatment was corticosteroid monotherapy followed by 5-ADA monotherapy. This is still the practice in the United States. Patients with UC, those with CD were rarely initiated on biologic therapy, with even fewer pathways identified using biologics as part of the combination therapy. This is at the time where all the guidelines stated these patterns were observed despite guidelines for UC and CD treatment that recommend anti-tumor necrosis factor biologic therapy as top-down therapy, alone or in combination, for patients presenting with moderate to severe disease. Furthermore, 5-ASA have been removed أساساً يعني from CD treatment guidelines, and the corticosteroids, when we use it, are meant to be used as bridge therapy to immune modulators or biologic therapy rather than as repeated courses without steroid-sparing therapy, as we found in 60% of study patients. Here, that is the practice in the United States. There is suboptimal treatment with bad impact on clinical outcomes, although many treatment options are available for moderate to severe patients. Healthcare providers are not optimizing advanced therapies such as biologics as recommended in the current clinical guidelines for patients with moderate to severe IBD. Why? What are the barriers? The barriers that in this lecture country where a lot of money for patients, what are the barriers? Several possible barriers to biologic initiation include patients and the providers' concerns over side effects. They are concerned about side effects more than the efficacy, more than the complication of the drug, and of the complication of the disease. Even the side effects are not truly present. Also, multiple steps needed to initiate and maintain biologics, such as baseline and following follow-up testing, therapeutic drug monitoring. انك تكتب كورتيزون للعيان that's very easy. انما لما تقول له biologics وروح اعمل screening for multiple infections ده بيعتبر مشكله عند ناس كتير قوي. Require the logistics regarding injections or infusions. Perceived reluctance by payers to fund the treatment for chronic diseases. However, results from a recent market analysis of U.S. health insurance policies on biologics for IBD suggested that biologic use is covered for most patients, and the real hurdle may be clinicians' perceptions. الحقيقة المشكلة عندنا احنا، المشكلة عند الدكاترة ان هم اللي يبتدوا التوب داون in its place في العيانين اللي عندهم moderate to severe regarding clinicians' perceptions regarding coverage or lack thereof for specific treatment. دي المشكله. الباريرز اللي موجوده عندنا هي اللي موجوده عند كانتري اغنى منا بكتير جدا. طيب ليه احنا بنتكلم على السيكونسنج التسلسل؟ Why does sequencing matter in IBD؟ الحقيقه ده مهم جدا because the armamentarium for treatment of IBD are full of drugs. Now we have first class, second class, third class, and many other drugs are coming. We are talking much of time about clinical and endoscopic remission. Deep remission, clinical and endoscopic remission is only achieved in less than 30%. When choosing a first-line biologic, that's an important question. Consider a plan for lifelong treatment. الحقيقة وانت بتختار الأولاني خلي بالك من المستقبل وضع الدواء ده ايه. Initial therapy والstatement دي is very important. Initial therapy choice can impact success of possible future therapies. الاولاني الدواء الاولاني اللي هتستخدمه عينك على الديورابيلتي اوف ذيس دراج. if this drug fail the second drug can work or not, and if it works does it work efficiently, or if you choose the first drug this second drug will not work properly. And for sure your eye for inflammation control, you need no disease symptoms, you need mucosal healing, you need your patient a good fitness, good metabolic health, good cardiovascular health, and high quality of life. That is the situation. We have infliximab, adalimumab, vidilizumab, ustekinumab, and tufasitinib, and there are many drugs in the late stage development. For sure, when you choose a drug, you need a synergistic mode of action. You will want a fast induction and high sustainability. So almost ask about your drug. Is it a fast action induction? Because it's fast induction has low sustainability, or slow induction and high sustainability. For sure, you need fast induction and high sustainability. How do we optimize treatment decisions when considering advanced therapy sequencing? This statement is very important. Determining the right first-line therapy sets up your patient for success. What factors should be considered when choosing a first-line biologic? Now you will choose anti-TNF, you will choose anti-integrin, or anti-interleukin 23/12. First question, does this first-line biologic therapy affect efficacy of subsequent treatment, as we will see? Does your first-line biologic therapy hit the right target of disease pathophysiology? How does the safety profile of therapy influence patient acceptance of treatment, dosing, and the route of administration? Can a specific mode of action of first-line therapy impact the efficacy of subsequent treatment? How does sequencing matter in the context of a patient's lifelong treatment? Do disease duration from the start and the disease severity impact the efficacy of your treatment? These six questions are very important and will guide you to which drug to be used. Based on efficacy, what do the data tell us about first line, second line, and comparative efficacy between the drugs? And you must ask based on safety. What do the data tell us about how the safety profiles of biologic therapies may affect sequencing? And proposed sequence of biologic therapies, how can we conclude based on available data about therapeutic sequencing? Which therapy and when? Efficacy of prior anti-TNF therapy. Now, adalimumab in UC and ulcerative colitis has shown reduced efficacy in anti-TNF exposed patients. As we see, if you use adalimumab in anti-TNF naive, mucosal healing in about 50% occurs. But if your patient is anti-TNF exposed before, it is nearly half, 28.6%. So the possibility of adalimumab to have a good effect in anti-TNF naive better than anti-TNF exposed. What about vedolizumab? If you use vedolizumab, it shows reduced efficacy in anti-TNF exposed patients. Here in according to Gemini study, efficacy outcomes for vedo induction therapy at week 6. Here in anti-TNF, yes, again, it is about 50%, but if you use it in anti-TNF naive, anti-TNF exposed, it is about 30%. So the question of sequencing, can we use it in anti-TNF naive or from the start? That is a question. What about tofacitinib? Hasn't shown reduced efficacy in anti-TNF exposed patients. Despite there is a difference between it in anti-TNF naive versus anti-TNF exposed, 38% to 23%, yet it is not significant. Is not statistically significant. The same also, ustekinumab hasn't shown reduced efficacy in anti-TNF exposed patients. So the results for biologic naive equal to biologic failure patient exposed to anti-TNF, there is a difference, but not statistically significant. So from these slides, if you wanted to use a biologic therapy with a patient failure before or failed before for anti-TNF or anti-TNF experienced before, for sure, ustekinumab and the tofacitinib will be similar confidence for each biologic in Crohn's disease. Vedolizumab induction efficacy at week 6. Too much talks about the late onset of action of vedolizumab, but here at week 6 there is a response of about 31% response according to the CDI 100 response. So in some patients it may work rapidly, not all patients. Vedolizumab demonstrated similar CDI 100 response in anti-TNF failure and the overall population. Here's the situation in Crohn's disease as regard those with anti-TNF failure before is better than in ulcerative colitis. Also, vedolizumab demonstrated early symptomatic improvement. Here we can see at week 6 there is a big difference between placebo and vedo, and it is present in either in Crohn's disease anti-TNF naive and anti-TNF exposed. Whenever you are comparing different studies, please have a look on the study design, on the CD duration, and the endoscopy score reported in the CDI scoring system, prior use of anti-TNF, and the factors like inflammatory markers like CRP, because these are determinants of the efficacy of the drug. Another item about anti-TNF therapy with adalimumab induced the mucosal healing at weeks 12 and 52. About mucosal healing, it shows mucosal healing at week 52, mucosal healing with scoring systems, the CDEIS remission, and it is at about week 52, about 22% of patients. Vedolizumab induced also endoscopic remission and response and the complete mucosal healing at week 26, and it is present in anti-TNF naive and anti-TNF failure. That's in Crohn's disease, which is better than in ulcerative colitis. The whole results of vedolizumab according to different criteria of mucosal healing. There is complete mucosal healing, which is present at week 26, about 31% of patients according to the Versify study. What about endoscopic remission rates by baseline disease duration? As we said, duration of the disease is matter. In the 26-week study population, very important, if you use it early, before 1 year, it reached about 40% of patients will have endoscopic remission. But if you take it more than 3 years, but less than 7 years, and more than 77 years, the results is very disappointing. So if your patient has multiple cycles of remission and exacerbation using the classic therapy, you give him corticosteroids, and then he will be in remission, then exacerbation, and the multiple years occur. Here, if you give him a vedolizumab, which is a very powerful drug, if you give this drug, it will not work as you will expect from it. What about ustekinumab? Improved endoscopic outcome with increased dosing. Here you can optimize your drug, and in comparison between 12 weeks and 8 weeks, it shows that every 8 weeks, if you give ustekinumab, the results is significantly more than 12 weeks drugs. What about efficacy by prior anti-TNF therapy in Crohn's disease? As we said, adalimumab has shown reduced efficacy in anti-TNF expression like you see. Also, Vedo, but to some extent better than UC. But ustekinumab, which shows efficacy in anti-TNF experienced in UC, here it is reduced in cases of Crohn's disease. The reverse. What about efficacy by prior vedolizumab therapy? If you give Vedo and then your patient failed therapy, can you give him anti-TNF? Let us show this important study, clinical effectiveness of first-line anti-TNF therapies and second-line anti-TNF therapy post-Vedo discontinuation in patients with ulcerative colitis or Crohn's disease. Here, the second-line anti-TNF effectiveness in ulcerative colitis is demonstrated even in patients with prior anti-TNF or anti-TNF with prior vedolizumab or or if he is naive. So the treatment response here nearly effective as a first line or a second line. So if you use Vedo as a first line and there is failure of Vedo, you can use anti-TNF and it will work the same as it works in anti-TNF naive. Also in Crohn's disease, results suggest that first-line Vedo may not impact the effectiveness of subsequent anti-TNF treatment in real clinical practice world. What about the comparative studies between them? Bio-naive UC patients receiving Vedo are significantly more likely to persist treatment than anti-TNF, and here all the results and all the parameters, either clinical response, clinical remission, mucosal healing, are in favor of Vedo if used as a first-line therapy. Also, vedolizumab was superior to adalimumab in achieving a clinical remission. Here it is head-to-head study, and here in primary endpoint, if it is used in anti-TNF naive or anti-TNF with prior exposure or failure, here Vedo shows superiority over adalimumab. Higher rates of endoscopic improvement were achieved with Vedo as adalimumab versus adalimumab in overall and anti-TNF naive population at week 52. And the differences, which is very important in clinical remission between Vedo and adalimumab, were sustained to week 52. That's important, the durability of the success of induction therapy. What about safety? All are concerned, either patients and the physicians are concerned about the dosing, about the side effects, the adverse events, the infections. All are interested to be safe in this point. Naive patients treated with VIDO were significantly less likely to experience serious adverse events and serious infection than those treated with anti-TNF therapy. So whenever you are tailoring your patient, whenever you are deciding to give your patient a biologic therapy and you tailor the drug, if you are concerned or your patient is more susceptible to have infection, serious infection, or has comorbidity, and you are afraid of serious adverse events, for sure the new drugs like VIDO or even stikinomab are better first-line therapy for safety concerns. So how do we decide the sequence of therapies in IBD? I think this is the job of the Egyptian society and all the societies in Egypt to propose which biologic therapy, keeping in mind and considering the financial state of our country, the picture or the characteristics of the Egyptian patient, the story of diseases in our country, HBV, HCV, the malignancy. All these must be considered to put a consensus, and I ask, and I know the whole board of the Egyptian society are attending now. We must, in our closing remark, to put a proposal or to plan for project which biologic therapy to begin, how to tailor your first therapy. As the first slides I said, the first one is very important, and it will decide and it will affect your decision later on. This is the last slide, and I say it will be the country, whenever the country where you practice your medicine, treating your patient, to put a strategy. We will not say VIDO as a first line, anti-TNF second line, but here our society and the professor put the proposal to tailor the drug for every patient. And thank you.